So, good evening, all the participants. On the occasion of World Schizophrenia Day, on 24th May, IPS AP State Branch conducts this webinar today on New Year Fascination and Understandings in the Dementia Precox 2024. Yes, we have a Kriplinian personality here, Dr. G. Prasad Rao. We are very happy to have my brother active again after a brief spell of rest due to a minor cardiac issue. We all know that relapses in schizophrenia are mainly due to non-adherence to treatment. Non-adherence is mainly due to financial reasons and lack of awareness. With this view, we have been running a schizophrenia clinic on every fourth Sunday, every month, to provide free consultation. To provide free consultation and free medicines for a month for the last 10 years to BPL schizophrenic patients. About 100 patients utilize the services of our NGO, Manasa Schizophrenia Foundation. Thank you very much. With this, now I hand over the proceedings to our CME chairperson, Dr. G.V. Raman Rao garu.
Sir, good evening, sir. Am I audible, sir?
Yes, sir.
Yeah, this today's title by Dr. Prasad Rao garu about the new fascination and understandings in the Dementia Precox 2024 is very interesting and thought-provoking. As we all know, schizophrenia research has advanced so much in the past 1 century following Kreplin's classification of mental illness into dementia precox and manic depressive psychosis. Newer understandings happened in the neurobiology of schizophrenia, starting from the molecular level to the macrocerebral level. We know that schizophrenia is a brain disorder which unfolds itself in the late teens and or in the early adulthood. It is such a complex and heterogeneous syndrome that all patients with similar symptoms won't respond to the same treatment. It was now known that more than 500 risk genes, CN variants, and mutations have been identified. More than 2 crores of patients with schizophrenia exist globally, and 1/3 of them are not even diagnosed. Only 10 to 30% of the patients with schizophrenia, 10 to 30% of patients with schizophrenia are resistant to the treatment. 50 to 60% respond partially and they require treatment lifelong. So we know that in resource deprived countries like ours, duration of untreated psychosis is longer and hence the functional recovery is also poor in the majority of our patients. Several ongoing clinical trials like RECOVER trial of brilaroxazine and DIAMOND trial of urotorant and ADVANCE 2 trial of pimavanserin, especially for the negative symptoms of schizophrenia, and COR-XT, that is Janomelin and Tropsium, Pospium, targeting the muscarinic receptors, are all in the pipeline. These molecules target different receptors, like what I have told about muscarinic receptors, or the trace amine associated receptors, like TAR1 receptors agonism, and serotonin receptor inverse agonism and antagonism, and glutamatergic modulation. Unlike the old currently existing D2 receptor blockers. And there is a hope for the patients with the treatment-resistant schizophrenia as well as patients with the negative symptoms. I'm sure Dr. Prasad Rao garu will make this presentation more fascinating and enlighten us about newer understandings in the schizophrenia research. Thank you, Prasad Rao garu. And now it's my duty to introduce my good friend, Dr. N.N. Raj garu. He doesn't require any introduction, but it's a formality and my privilege to introduce Dr. N.N. Raj garu. And Dr. N.N. Raj garu has done his MBBS in the AMC and PG in CIP Ranchi, PG in both MD and DPM. And he was currently professor and head HOD for GVP Medical College, Vizag. previously worked as Professor HOD, AMC Vizag, as well as Vice Principal of AMC Vizag, and is the past Superintendent of JHMC Vizag, and also he was the former president. All of us know is national IPS, and also currently is the director of the Maharishi Institute of Neuropsychological Disorders. That is mine. Thank you, Dr. N. Raj garu. Please take over.
Thank you. Thank you, Dr. Ramanrao garu, for, in fact, this is the day of Dr. Prasad Rao, and the introduction of him is more apt than my introduction. I'm just perhaps, anyway, happy to listen to my own achievements in it. Thank you very much. Well, we have Dr. Prasad Rao, who literally doesn't require any introduction. He is perhaps the most famous Telugu psychiatrist in the country. Has been, I think, Sharath has given me a very small note of his introduction. Otherwise, if you really include every achievement of his, perhaps we could miss the talk altogether today. Most probably, entire 1 hour would be spent on his achievements. But in any case, what I have here is that we all know that Dr. Prasad Rao is one of the founder directors of the very famous Asha Hospital in Hyderabad. He is the president Indian Psychiatric Society between 2015 and 17. He was the deputy editor of Indian Journal of Psychiatry. He was the president Indian Association of Geriatric Mental Health, president Indian Association of Private Psychiatry, president Society for Bipolar Disorders of India, president Indian Association of Biological Psychiatry, president Asian Federation of Psychiatry. Currently, he is the president of Asian Federation of Psychiatric Society. Published almost 150 national and international papers. So really, I think he is one personality who has say in almost all fields of psychiatry, definitely in our country and more so in our Telugu-speaking states. And today, I'm really happy to see the words dementia precox back. Most probably a day has come that this term would again schizophrenia would be, this term would replace the current term schizophrenia. I think for those, I'm sure what he's outlining, he would be discussing. Dr. Raman Rao has given us some thought since the days of the term first used, I think if I remember correctly, somewhere in 1880. So literally more than 143 years, when Heinrich Schule was the first German psychiatrist who really used the term for the first time. Then it was Adolf Meyer who made it very popular. We know that Kraepelinian classification has come. Bleuler's term of schizophrenia arrived on the scene in 1911. And then the schizophrenia was more popularized because of the statistical documentation in American psych associations. These were the I would say, runners for DSM-1 in 1952. So this is how the evolution of to schizophrenia occurred, and I'm sure today the term of schizophrenia itself is quite a questionable term. The syndrome itself is questionable. Do we have such a disorder at all? Does such a syndrome exist at all? Are we unnecessarily bringing some unrelated symptoms and signs together and to bring to one group and then calling it schizophrenia? I'm sure this is beyond an ordinary person like me, but I'm sure Dr. Prasad Rao must be dwelling all these aspects and give us a direction where exactly this disorder is leading us to, and perhaps we are looking forward to his talk. So without much ado, let me get Dr. Prasad Rao onto the screen. Dr. Prasad Rao, the entire time is yours. Thank you.
Thank you very much. Thank you very much. First of all, it's my pleasure to be here once again. And it's time for us probably to appreciate what is going on in this field. Are my slides visible?
No,
Full?
sir. No, sir. No, sir. You need to share your screen.
Yeah, I'm trying to share my screen. Give me a second. Yeah, it's coming and going. Yeah, yeah.
Yes.
Now is it visible?
Yes, sir.
Yes, yes.
Okay. Really, really, I'm thankful to all of you for this opportunity on this World Schizophrenia Day, which we are celebrating probably today on behalf of the Indian Psychiatric Society, Andhra Pradesh chapter. I'm thankful for the CME chairperson G.V. Ramana Rao's initial introductory message on schizophrenia and Professor N.N. Raju's wise words and wisdom, which actually stirs today my feelings. I have used the topic like newer fascinations and understanding of dementia praecox, uh, as we see in 2024. And to start my talk, I have no financial conflicts to declare in this lecture, but I thought I would like to share with you. I am a clinician like all of you. I have been a researcher in schizophrenia and especially the drug development and a speaker for a lot of company. Hopefully, my biases will not cover too much into this lecture. I start with my respects to the chair, Professor N.N. Raju Garu, who is my dear friend, and we have journeyed too long decades to work. To the president, I pay my respect, as you can see in this cartoon. He is a quite hardworking and a shy person who works coolly behind. Namaste, sir. And thanks to the kind invite of Dr. Sarath Chandra Ivaturi, the Honorary Secretary of IPS Andhra Pradesh. I think over the last year, I've been attending almost most of the webinars, and I'm thankful for their rich contribution to this. My own attachment to schizophrenia disorder started way back as a young resident in the year 1981, to be precise, August 1st. And in my first few days, I was working with Professor Raghuram, who taught me the nuances of this. As very nicely put by N.N. Raju, Emil Kraepelin is, of course, was the one who was credited to be coining the term dementia praecox. And as N.N. Raju has correctly said, it was actually done by somebody. But we should go back to think, and at this point of time, I would say I'm influenced by two other Indian psychiatrists. I think in the Chennai conference, I think those days it is in Madras, ANSIPS, I was sitting with Dr. Abraham Varghese when his recording was going on. I still have his audio tape. When he told me the beauty of the schizophrenia as I heard him talking to the tape. But this wonderful gentleman, dementia praecox, and I'm really thankful that I could go and see along with MS Reddy, the center which he started and continues today also. More than 110 years back, this gentleman whatever he has said, even today it is 10% of schizophrenia, or though I will keep using dementia praecox in respect of him, would have a very good prognosis and they might recover. Science has not changed 110 years thence. And of course, his detailing of mood symptoms, his detailing of cognitive deficits, because of that the dementia praecox name was given, but he also talked about the positive symptoms and negative symptoms. Of course, the modern name of schizophrenia, the so-called split in the mind in the terms of functioning, was actually given by Eugene Bloiler, another junior colleague of Emil Kraepelin, I would say. Today, in this time allotted to me, I'm going to delve very briefly the dementia praecox as we see today, the understandings of schizophrenia, or the modern name which we continue to use, the reality, and why does it occur, why does it occur in adolescence to start with, what causes Is it dopamine or is it beyond dopamine? Is it the glutamatergic system? What is schizophrenia phenotypes today and the cognitive deficits, how to help, and the brain biomarkers, what is evolving in the last decade. I would specifically talk about the treatment resistance. Pharmacologically, what are the old and new molecules and what is the evidence says today. And today, in the end, I'm going to really give you what actually happened in the last 3 years. And please keep waiting for that. And finally, some few take home points. As you see, the causes of schizophrenia over the 4 decades of my journey, there were many theories and myths. Like many blind people describing the elephant, as you see in this cartoon, somebody said touching the ear of the elephant as it's a fan. Somebody touched the tuskers to say it is a spear. Somebody touched the. Somebody else said it is a snake. It's a tree. It's a rope. But let us see what has happened over the 3 decades. At some point of time, it has changed primarily into a developmental disorder, developmental process which is deranged in the nervous system. There was also the theories of autoimmune. Of course, way back in 60s and 50s when psychodynamics was there, the mother of the patients of schizophrenia were actually considered as the cause of schizophrenia. That is, mothers causing schizophrenia. Then there were the down, as you can see in this cartoon, you see, for example, the 2 antipsychiatrists, Thomas Lang, who said it's a spiritual breakthrough and not a nervous disorder at all. And there is this antipsychiatric kind of thing, it is a sane response to the insane world. But suffice for us to remember, schizophrenia is among the top 10 disabling illnesses in the medicine today. And this is a known fact today. But what has happened is, I think we started disproving no longer that mothers do not cause. Maybe they might cause from a genetic clouding, but not by their behavior, of course. And Thomas Lang's theory has gone. Likewise, Thomas Sa's core theory of it is a sane response to an insane world. What is probably left over the last 3 decades as we continued our journey to learn, at least my journey, it is now established developmental and dopamine. Having said that, developmental theory and what are the other factors in the developmental theory, I'm going to delve in the next few slides. Autoimmune, we have in proof. Dopamine, we have proof. But as I will show in the next part, most of what we think what is schizophrenia phenotype is actually what our patients tell. And I'm going to show you that a typical case would be like this. A typical childhood, the child has a poor concentration. Here I'm trying to focus on the cognitive deficits of a patient right in the childhood. And that's what a strong group of people who have studied for 15, 20 years follow-up of high-risk children have identified that there is a prodrome. And I'm now going to tell you a very important, there is this girl who remembers her mother as being cold and distant right from childhood, frequently silently feuding with father, a dentist with a bipolar disorder, and a maternal uncle with schizophrenia. This girl started showing some symptoms during late high school, around 14th year in her 8th, 9th class, when she was slightly socially withdrawn, daydreaming excessively. There was progressively declining grades in the 9th class and 10th class, and she used to worry that the classmates were spreading bad rumors about that. When she told this to the family members, they were not sure what's happening. At that point of time, and as you can see in this wonderful cartoon, I'm trying to show that in schizophrenia, it starts with a premorbidly, there are some cognitive deficits. There is a kind of a small prodrome, which if you can go properly to the history, you might find in some, there is invariably this acute psychotic episode when the patients actually come. And I'm going to show you what would happen later. So typically, when did my illness really begin? why in adolescence is a question normally asked by our patients in the family. How does my illness cause a chemical imbalance in my disabilities? And second common question, because we keep explaining them on the chemical imbalance, then why did I get this illness? And what is my diagnosis? Do I have one disease or many? And so on and so forth. So in my next part of my presentation, I'm going to cover some of these questions, especially focusing on the last decade. A typical story of this patient, which I started during her college student, she was convinced that her professor was stalking her and also hearing a voices of multiple, the deceased grandmother and others. She was treated with haloperidol initially, and subsequently, 4 years later, she continues to remain to hear the voices in the head. She did not work, she is unemployed, she was a dropout, she had depressive symptoms and a manic symptoms in between. So we did consider shift in diagnosis, but subsequently she's continues to be sick. So this cartoon probably summarizes what we know till this point of time. There is, as I said, pre-morbid phase where cognitive decline actually starts very early in the childhood, and there is a prodrome phase which is again a varying thing where there is an anxiety symptoms or an obsession symptoms, but a decline can be seen, and a first episode is the time when they come to us. Following this, as I told, 15 to 20% of them are really lucky to have just one episode, but majority of them actually have multiple exacerbations and remissions. And it is now known that at the end of 5 years they might bottom out, but doesn't mean that they would recover, but it only means this happens. Now I will start answering what we know in the last decade. We now agree that one of the hypotheses which was well established by psychiatrists from our country origin is that there is probably, as we at birth neurons proliferate, and the maximum neuron migration actually occurs during late childhood and early adolescence. But one strange thing keeps happening around this time. The neurons actually prune. And regarding this, psychiatrists from our country origin who are working in the United States actually came out with a clear evidence in the last 2 decades. And what did they find? And this, if you go back in the year 1982, when I'm the young resident, I remembered Feinberg commenting that probably schizophrenia is the result of some abnormality in the process. It might be because there might be too many or too few of the wrong synapses. How beautifully described without any neuroimaging. He actually said, as a consequence of this bug, that is too much of a pruning. Bug is a genetic program. That's what he hypothesized at that time. He felt that defects of the neuronal integration developing, and what we now call proning is dopamine systems is involved. Having said this, I think the second important theory, as I keep talking, Macheri Keshavan, whom we should really appreciate, is a person who, way back in again 1998, talked about is schizophrenia due to an excessive synaptic pruning in the prefrontal cortex. He actually commented in the Journal of Clinical Psychiatry on the Feinberg hypothesis revisited. Now, what we know, and this is a summary of what we know, a variety of authors, as you can see, from 1975 to 1998, they have identified that varieties of neuroimaging technique. They found that the synapse density is less histopathologically in schizophrenia patients, patients of schizophrenia or dementia praecoxy. The gray matter thickness actually comes down. Remember, Crow had made an hypothesis of type 1 and type 2. The prefrontal metabolic rate has actually reduced, and that is probably one of the PET scans done by Chugani, and the delta sleep pattern, which is again connected with this, and the prefrontal membrane phospholipid synthesis is reduced, again another MRI finding. Now, the observations consistently is that there is an exaggerated synapse pruning in all the patients of schizophrenia. And as you can see around, there are at least two important papers, including Andreasen, Keshavan, and Pettigrew and Keshavan. They have confirmed of this. So this is one of the known hypotheses. And I'm going to show you a few cartoons and synapses. what is important is the adolescence is a period where the neuronal cells actually divide quite heavily, but also something suddenly happens, and this is again identified very well in the by Glantz and Lewis by these famous histopathological studies. Actually, glial cells are supposed to eat away the unnecessary cells or cells. So what they have identified in the 2019, the most recent, again confirming the old hypothesis by Stefan et al., is that the synapses actually become underactive, and glial cells start eating away the synapses, and the complement protein actually comes down. So this microglia eating away the inactive neurons is probably much more, and this probably is triggered by an immune mechanism. Remember, we talked about a neuroimmune hypothesis. Today, we have evidence for this part of the theory. And this is one of the electron microscope picture. As you can see, you can actually see a glial cell eating away. And this is what I borrowed from the Dr. Keshavan. Now, what subsequently, lot of other things, that emergence of a neuronal connectivity and expansion of white matter lesions is again established. Something like this cartoon again, the beautiful green has gone away in adolescence to live like the modern township where the green is gone away, but you have a lot of roads. But unfortunately, the connectivity is lost, though the connection within the people by road is improved. I think the greenery is lost. The neurochemical regulatory pathways are fine tuned, and by this is another one which would explain, as I said, excitatory glutamatergic neurons actually dominate during adolescence. And as you can see, during adolescence, in this cartoon, you can very clearly find that between 15 to 25, there is a maximum glutamatergic activity. And as you can also see, the dopamine neurons actually start little late, between 15 to 25. Glutamatergic system actually starts operating at right from the childhood, but dopamine starts late. And intermediate wise, the inhibitory GABA neurons takes over to balance these three. So this hypothesis, and Thomas Insel, the NMH director between up to 2013, actually has given the neurochemical regulatory pathways are fine-tuned during the childhood to adolescence, but something wrong happens in the children. And he has hypothesized that the connection between the LCN in midbrain and the prefrontal cortex, which is mediated by glutamine, might be the cause. And as you can see in this cartoon, the imbalance between dopamine, GABA, and glutamine pathways is, and GABA is the red signal, glutamate is the green signal, so it is the controlling factor might be related. As you can see in the cartoon, most of us, when we see we talk young man, go to the room and stay till you. I mean, there's a cartoon which depicts that all through the adolescence, most of the time the adolescents are suppressed by the adults. But during the puberty, which is probably the brain stops automatically adding new connections and starts pruning away the excess. This is one of the hypotheses. And now I'm going to show you, in addition to the pruning hypothesis, what are the other factors which we found in the last decade. Familial high risk offspring, one of the McGorry's studies has clearly what, and our own Divadkar actually has established by the neuroimaging. And as you can see in the second cartoon, this is the real images of our schizophrenia patients done by multiple researchers, which you can see very clearly in this neuroimaging, that you do not find kind of neuronal cells. The red ones are probably the damage which is identified quite early. And the childhood onset of schizophrenia is now well established, most of us agree. And the reduced synapse density is again re-established by the data. Now, with the high-end MRI machines, and this is one of the picture I'm showing you, is an MRI which is done with 9 Tesla. You can actually differentiate between normal controls, ASD, and schizophrenia. As you can see in this arrow, you can see the amount of damage which is recorded and can be identified. Having said that, during my time, it was very easy for us to understand schizophrenia. Too much dopamine is the oldest theory. I would call it the classical theory, which was the dopamine nexus. But it slowly changed over the period. And as you can see, the current hypothesis was actually again given by our own Kshitiz Kapoor, along with Hose, who actually said the primary defect of schizophrenia is not dopamine excess, but it is the presynaptic. Now I'm going to show you the summary of what we know today. For anybody to develop psychosis, we agree too much limbic dopamine is the cause. But why does this occur? And this is well established in the meta-analysis study, which I'm showing here. And as you can see, the emerging model which is accepted today, that is, I'm quoting this as a 2013 to 2019, the emerging model is the GABAergic interneurons is now considered as a starting point, and the GABAergic receptors actually lead to and slow down the glutamatergic, which is the red pathway. And as you can see in the green, the decreased mesocortical dopamine function also starts around that period. I will explain because the negative symptoms are now explained by two important mechanisms: the failure of neuronal synchrony because of excessive pruning, and the primary defect of dementia praecox is cognitive symptoms. What we can also call as a negative symptoms is due to a balance of two factors: decreased mesocortical dopamine and the failure of neuronal synchrony. Now, I would say, why did I get this illness is a common question. And what you see in this picture is the beautiful Manhattan kind of a photo. And genetic studies, as you can see very clearly, this is 108 gene loci are responsible for schizophrenia. And this is published in the Nature, one of the largest sample of schizophrenia population. And what you see is the interesting part is the biggest contributor is HLA major histocompatibility, followed by glutamate, developmental, and channel genes. So these actually further supports the hypothesis that some way glutamate pathway is responsible. Of late, the further analysis in the last 5 years is Ashwin Shekhar et al. From has published that C4A expression increased schizophrenia. This is published in the Nature in the year 2016. And there are again a few more genes which might help to us to understand that the excessive synapse loss is because, and this is well established. This is a further contribution by Keshavan et al.'s group, both in 2008 and 2014. Here, this graph is a very interesting graph. The environmental factors and gene environment interaction is putatively explaining the summary. So, at this point of time, my summary would be that schizophrenia results because of an exaggeration synaptic pruning, and this is due to multiple factors, and underlying structural, functional, and connectivity leads to synapse loss, and psychotic disorder occurs because of polygenic and poly-environmental factors. Some of them we know already, some of them are still emerging at this point of time. So at this point of time, I change gears. What do we understand? What do we do not understand? I'm going to spend the next few minutes. Today, we understand schizophrenia as a multi-phenotypic. About 40 to 50% of our patients present with positive symptoms right in the first psychotic episode, which are characterized. Remember, only 40 to 50% present with hallucinations, delusions, and so-called formal thought disorder. Today, we are not seeing too much of a formal thought disorder for a variety of reasons, but it was very prominent during the dementia praecox types of Emil Kraepelin, as you can see in this cartoon. The cognitive impairment is the core aspect of disability of schizophrenia, but we also see in the lifetime affective components do present in 40 to 50%, along with anxiety. And many of the times now it is very clearly evident that the anxiety due to stress induced relapses are very well understood. Cognitive deficits occur in 80 to 90%. Then what would happen to the rest 10%? They are the lucky people who do not have. And today we are left with significant negative symptoms. And as we know, as we understand today, we understand that negative symptoms and cognitive deficits we do not really have good pharmacotherapy. And I'm going to talk to you about what is in the last 5 years, can we improve cognitive deficits? I'm starting with a positive note in the sense that pharmacologically, though there are no evidences, what happened in the last 5 to 6 years that the cognitive deficits, which are the primary deficits of dementia praecox, can actually be worked out by a newer technique, and that is called neurocognition. The speed test, the memory test, the attention, the reasoning, tact and social cognition. And one of the contribution from Nimans is that along with the world contribution to schizophrenia, is that schizophrenia patients do have impaired social cognition. I'm going to touch a base on this, that neuroplasticity is an activity driven, as you can see in this cartoon, the action potential generated by, and we are connected, and neuroplasticity is an activity driven. Now, what we know also at this point of time, that the balance between cognition and learning is lost in schizophrenia patient. So use it or lose it depends on how we go about. Now I'm now changing the newer treatment modalities. The evidence is now emerging. The TMS, especially the modern TMS, seems to be improving some of the negative deficits. And it's not the classical bifrontal or target, it's the deep RTMS. Now, an emerging hypothesis is, the data is emerging that we, through RTMS, if you stimulate cerebellum, probably cognitive deficit will improve. I'm going to show you the synaptic pruning, as we can't do anything for that. But what we can do is probably how to correct the deficit from a biological point of view. As you can see in this cartoon, deep RTMS, and not referring to this figure of 8 coil, I'm referring to the more specific deep RTMS, which is now available. And right now, the second important treatment as a positive evidence, which was initially published by Wykes et al. And you can see this is a meta-analysis that cognitive remediation actually works, and it is better than antipsychotics for community functioning. And this is the data, as you can see, Hogarty et al. Published, Schwartz et al. Published the larger data initially, but right now we think that the treatment effects of cognitive rehabilitation
ప్రసాద్ సార్ మీ వాయిస్ రావట్లేదు.
for our patient of schizophrenia is a must. So a program for lasting between 1 to 1. Okay. Now, okay, the cognitive enhancement therapy by improving attention, memory, and problem-solving modules done in pairs with computer exercises now actually helps. And second treatment, which is found to be beneficial in the recent times, is social cognitive group therapies. In a group setting, we can actually improve by improving their non-verbal communication and emotional temperatures. This is one area which has emerged quite recently, and last 5 years we have a lot of data on cognitive enhancing, and you can make the patients do these exercises in the treatment. And these are the 2-3 studies in which chronic patients, initially small sample, subsequently larger sample, has clearly shown improvement in social cognition compared to the non-treatment group. And again, we right now have evidence that fMRI studies have shown that following CET, there is a significant change, and amygdala and all the sites. But the newest evidence is something which has emerged, that not only they last, but they last for more than a year. Essence study is one which has shown this. Following 10 years after the treatment of CET, the cognitive enhancement treatment, the patients continue to remain cognitively better when compared. So this is the real world benefits which I think we should start using, not just pharmacotherapy for our negative symptoms. There is yet another study called CLUES, which has studied about this. And as you can see very clearly, global functioning, social functioning, and others did improve. Right now, we do have something like an X box in which the patients are trained to do a computer cognitive training. And as you can see, verbal memory, digital span, take motor, verbal fluency, and all improved following this. This is again a very recent publication in the year 2010. Keshavan, Sandoval, and Tandon has published in the year 2020. And virtual reality is the newer mode. Here, the cognitive enhancing exercises are done through this. What is important for all of us? Sleep is most important for cognition improvement. This also has a place in dementia as well, but in chronic negative schizophrenia patients also, when compared to control, schizophrenia patients do have a disturbed sleep spindles, and data has emerged very clearly that if you improve the sleep by some form, and the most recent, as I said, we are now targeting through TDCS cerebellar networks to improve the negative symptoms and possibly cognition. I'm sure the next 5 years, this data is going to be much more robust for us to practice daily in our own clinics and give a good recovery. Now I will come to the pharmacotherapy part a little bit. I think compared to all these 3 decades, we had serotonergic and dopaminergic drugs, but anti-dopaminergic drugs probably had a good run. But as I show in this, CBI, that is the cannabidiol agonist, GABA modulators, antioxidants, neuromodulation, anti-inflammatory, cognitive remediation, and serotonergic agents are likely to be. And I'm going to show in the next part the evolving psychosis patients. The take-home points are very simple. Phenomena of neuroplasticity is one now came to stay, and we now know very clearly that we have to improve this by lot of things which are very simple: sleeping properly, eating proper diet, and of course cognitive remediation. And henceforth, the negative symptoms and cognitive deficits can be improved. We have to improve this, reduce this sedentariness, and make them more active. But there are still a lot of unmet treatments, and which I'm going to spend. For example, how to make a diagnosis. DSM-5 makes a lot of money by selling the books, but it's a useful shorthand. But consistent, it helps us to become more consistent between the doctors. But does it tell about the disease? My answer is psychiatric diagnoses currently are reliable but not really valid. And this is true even for schizophrenia. And now I would come to this third part of my presentation to talk, did we come out with any new brain biomarkers? Regarding brain biomarkers, I think we have tried for quite long about the electrical things, but the disease and the process, symptom-based diagnosis is the one, but biomarkers, the cognitive tests, EEG, and machine learning is just started coming. Now, this is one of the analysis done by Keshwan's study, which is a replicated study in the year 2008 and 2014. The sad news is that all the 3 psychoses, one is the bipolar psychosis, bipolar mania psychosis recovery, one is the schizophrenia, and the other is psychosis NOS. They do not differ on these subtypes. But having said that, there seems to be a difference between each disorder, and that is the data from Keshwan et al. But what is emerging, and as you can see in these beautiful cartoons which I picked up from the MRI images, the hippocampus is probably the source, and the biotypes are different. Biotype 1, 2, and 3, for the sake of naming, are different in terms of the both neuroimaging and the variety. For example, an underactive one leads to one kind of negative symptoms. Overreactive, that's the mesolimbic hyperactivity, leads to the positive symptoms. But all look like a healthy brains, but within they are different. And the newer emerging therapies, apart from clozapine for the treatment resistance and negative symptoms, is the computerized TDCS, altered TDCS, which are probably going to come in the next few years. So, in summary, biotypes are emerging. We need a stable, replicable, but at this point of time, some are there. Take home points from at this point of time is schizophrenia probably, as what Kraplin said, polygenic disorder of synaptic integrity, several innovative targeted interventions are now being done to address the cognitive and negative symptoms. Of course, for positive symptoms, I will now summarize in the next 5 minutes the pharmacotherapy of schizophrenia, what we do today based on the evidence. And this is one of the Stephen Lush et al.'s article, which probably is the best to give us which molecule is the best, and no prize for guessing. Clozapine is the best, followed by amisulpride, followed by olanzapine, followed by risperidone, followed by haloperidol, followed by zotipine and quetiapine. Now, ladies and gentlemen, most of us use almost in some order the second, third, fourth, fifth, and I'm going to present some of the data. This is yet another paper, which is again network analysis published in the Lancet by Hoon et al. Again, it also came more or less like a similar. Clozapine is the top, amisulpride, zotipine, olanzapine, risperidone, perfenadine, and thioridazine in their network. And what is important for us to understand is most of them target only the positive symptoms in the systematic review. Out of the 32 antipsychotics which were clinically tried in multiple studies, this systematic review talked about amisulpride, risperidone, clozapine, olanzapine, and paliperidone in some order. But I'm going to show you very quickly as a snapshot, as told by N.N. Raju, I think, not G.V. Raman Rao, I think, the new emerging molecules, out of which cariprazine has a role for depression and negative symptoms. As you know, these are all polyreceptor active molecules. Lumateperone is something again likely to be different when compared to others, and this is approved in the year 2019 by US FDA. It is simultaneous modulation of serotonin, dopamine, and glutamate. This is one of the probably early molecule. And when I talked to Thomas Insel recently, he talked that this molecule is going to have a much better place. In the pipeline, there are a few more molecules which are there, and glycine modulatory sites for the negative symptoms, and glycine T1 inhibition, antipsychotic effects, and drugs in the pipeline. There are a few different, as I said, PDE10 inhibitors is one, sodium nitroprusside is their nitrooxide donor. That's one more. Cannabidiol, oral cannabidiol. I'm in the process of developing this trial, though there is one negative trial. I'm just started one. Pimavanserin, again a 5-HT2A inverse agonist ongoing, is almost approved by the US FDA. But the data right now is not so great for negative symptoms. There is, out of the two studies, one is positive for negative symptoms. And in the last part of my study, my presentation today, I'm going to touch on two important areas which probably we are neglecting. How to treat the advances in the treatment resistance. When we call treatment resistance, we actually talk mostly for positive symptoms. We don't really talk about negative symptoms or cognitive symptoms. But even, for example, persistent hallucinations might be a common thing. But what really is so, as already said, 30% of our schizophrenia patients, no matter whatever you give, are resistant to the pharmacotherapy. But over the period, this group, treatment resistant schizophrenia group, treatment response and resistance, a group was formed in the year 2012 by the top psychiatrists of the world who are working on schizophrenia. And what is important is the definition. There are about 34 definitions of treatment resistant, but this group came out with this important summation. The diagnosis should be based on well-documented failure to respond to two antipsychotics, clearly documented history of treatment failure of at least one antipsychotic, plus validation of dose and duration. Initially, it was considered 6 weeks, but today we are considering as 12 weeks of treatment. And this TRIPS in the most recent publication in the year 2017 has commented that proper assessments in the study has been needed. So with this, actually the evidence is coming. There are two are three important subtypes of treatment-resistant schizophrenia. Here, clozapine is beneficial only in one type, the type A, which is called hyperdopaminergic system, whereas in which there is characterized by striatal dopamine elevation, whereas normodopaminergic system type B, the clozapine is not responsive. But I would also appreciate that treatment resistance should be defined well and should be separated from pseudo resistant schizophrenia because of non adherence, as talk commented by the chairperson. Concomitant substance use is one of the modern malady, especially the cannabis, comorbid medical disorders and the medication, and adverse and detrimental psychosocial. And I'm here to say that psychosocial treatments are as important as pharmacotherapy, especially in these chronic disorders. Now I'm going to give you the final summation and rethinking of schizophrenia, the Circa 2024. Very recently, about 2 months back, a project was started about 2 years back, reinventing schizophrenia and updating the construct. They went on to study, and this was published in the this year, actually 2 months back, by Tandon et al. Tandon being Rajiv Tandon being the main author. They went on to question three important questions. What is our current construct of schizophrenia? Are we all talking about the same construct or different? Is it viable or salvageable? Why or why not? So that was the first question. If our current construct is wrong, what is the alternative construct which they existed? And what strategies and methods are necessary to validate the existing or the new construct? So this with these three questions, the top people in schizophrenia, you can read these names. They're all among them. I think we have Tara Rangaswamy from our country. We have Macheri Keshavan, and we also have, of course, Rajiv Tandon, Henry Nasrallah, and a lot of other people who have worked for, according to them, 180 hours interaction. I'm going to present what is the brief synopsis, what we know about schizophrenia. I think right now we agree that etiologically we agree on genetic and environmental factors. Pathology wise and pathophysiology wise, we agree on certain dimensions. Clinical features, we agree there are the 5 to 6 dimensions: positive, negative, cognitive, affective, and disorganized type. Of course, motor symptoms also come here. The course we broadly know, as I presented it right in the beginning, and outcome and the treatment, essentially, though pharmacological, we also talk about psychosocial. Whatever the DSM-5 and ICD-11, the constructs are essentially same.
ప్రసాద్ సార్ వినిపించట్లేదు.
మళ్ళీ అన్మ్యూట్ చేయాలి బాబు.
సార్ హీస్ ఇన్ అన్మ్యూట్ ఓన్లీ. ప్రసాద్ సార్. ప్రసాద్ సార్.
Hello, Mr. Aravind.
There does not appear to be any singular commonality here. So these experts have come to this conclusion, suggesting that probably, but I also would say the reality of schizophrenia to diagnostic test exists today. Necessary or sufficient pathology, no necessary or sufficient constructs of what we know. And of course, despite impressive advances in the available methods, example, molecular biology or brain imaging, there is only a modest improvement in the outcomes, and we need multiple treatments to go about. So from this complexity, these authorities summarize that psychosis, we should accept the reality. The psychoses are heterogeneous, symptom-based diagnosis only we are making. With, of course, we have our own constructs for biology, genetics, and outcomes trajectories. Clinical, biological, and etiological definition of disease states in psychiatry likely do not exactly match with each other. So sometimes what I consider schizophrenia might be considered differently, and that's why Sisyphean proposition might be useful. But the accumulated and enormous amount of information which is coming day in, day out, collectively tells about broadly about the nature of schizophrenia. At this point of time, we need to accept that heterogeneity, symptom-based diagnosis, but there are multiple unmet therapeutic needs, psychopathology wise, comorbidity wise, adverse outcomes wise, societal and healthcare problems, and others which we don't know. And obviously the cognitive deficits, negative symptoms, mood symptoms, and psychopathology wise, and substance use comorbidity is another challenge which we are facing at this point of time. So how do we get there where we want to get? I think to know where we want to go, to know where we are, and know the best what we can do today is very essential for us to understand. And I'm summarizing whatever I know at this point of time in this wonderful graph. The concept, disorder criteria, whatever they are based on structural, functional, and neurochemical abnormalities underlying, and the risk factors we know to some extent, protective factors we know something, modifiers of the disease we know something, but we still have to know little more on the description. So defining a disorder, knowing what it is, rapidly multiplying. The nosology has to is better, but still we need to go much more to incremental advanced definition of schizophrenia. And understanding the disease process is very important. Having said that, I think each one of us should contribute our understanding by giving the depiction of this disorder in varieties of forms and trying to improve our own conceptual understanding. So, what is 30-30 going to be? It's going to be, as I said, probably the worst thing is to call the death of schizophrenia. I don't think that would happen. No longer a viable unitary construct. I don't think that is true. There are hundreds of schizophrenias. We agree the hundreds of phenotypes, but efforts. So living with the unitary schizophrenia is better even today. And what dementia praecox, as called by Emil Kraepelin, that still is there, but we have an increasing understanding, as you can see in this beautiful picture. The two high level trends of circa 2024. And ladies and gentlemen, it is my saying that the dementia praecox still exists as its form. And thank you, ladies and gentlemen, for this long, patient hearing. And I think time has come for me to answer some of your questions. Thank you, ladies and gentlemen.
Thank you, Dr. Prasad Rao. It was a very exhaustive, excellent, and also quite a mind, I would say,
1 second, I'll just
twisting
come.
lecture. Very difficult for some, might be require a little bit of advanced thinking. That is exactly what the seminar is all meant for. But I'm sure a lot of people will have questions. So especially the younger people. Uh, I'm not anything in chat box. Sharath,
Right
nothing,
now, nothing, sir.
nothing,
Right now, nothing.
nothing,
Right now, nothing, sir.
nothing.
Nothing.
Anyone? We have almost 75, 80 people watching this, and
Anybody can unmute and they can ask questions.
yeah, see.
Yes, Senanraj Garu. Sorry for the minute.
No issues. Anyway, there are no questions, but the problem now we have is one thing: we are abandoning this neurotransmitter theory, and we are developing drugs based on again the same theories. How do we correlate these two?
That's an interesting thing, but I don't think we have. See, what has happened was initially we started with a simple dopamine access theory, and the first generation antipsychotics were all consistently antidopaminergic. What happened is after clozapine, the atypicals started coming where we have multi-systematic. We have not really abandoned the neurotransmitter theory. But as you say, now we are more specific. One of the new molecule which I'm now working on is an H27, H2A, and of course D3. You remember this three is a combination of cognitive, and right now that's in the phase 3 development. It has proof for the negative symptoms too. So what we are looking is not really abandoning the neurotransmitter. We are looking for probably more precision. And as I said, cognitive enhancement therapy, which has to be practiced for the benefit of our negative and cognitive deficit patient. That is one more area which we are which also has that it actually improves the prefrontal area. So obviously, I think we are going strong on some of the things, but we are still not there. And the one which I quoted of Rajiv Tandon is probably the top schizophrenia patients, schizophrenia workers who are coming out with a new hypothesis. This is published in the recent journal, very recently, 2 months back.
Raman Rao garu, any question?
Only appreciation, sir. No questions. Prasad Rao has given a global, outlook about what is happening during the contemporary, psychiatric field. I really appreciate and thank him for the enormous knowledge and top class presentation. Really, hats off to you, sir. Thank you very much.
Thank
There
you,
is
Raman.
something in the
Sir,
chat
good evening,
box.
sir. Good evening, sir. Prasad Rao, sir.
Nagireddy garu, namaskaram.
Nagireddy garu.
Sir, namaskaram, sir.
Namaskaram.
Sir, one thing, sir. So science is so much advancing. Why you could not able to unlock the mystery of schizophrenia, sir? I really wonder.
I would take it as a positive comment also. See, it is such a complex, fascinating disorder, and schizophrenia is not a unitary disorder. Like diabetes, I keep comparing because each diabetic patient is uniquely different. Only difference is it has much better biomarkers and all. We have unlocked quite a lot of secrets over the last 2 decades. But yes, I agree with you. The entire answer is not there. One of the reason I think is that we are looking for a simpler solution for a complex problem, which is probably polygenic, different phenotypes, and uniquely distinct. And what has happened is the answers, if you are looking for a complex problem with a simple solutions, you won't get the answers. And today, I think we look for personalized, patient-centered therapy. As I said, for a cognitive deficits or negative, we just end up. And pharmacotherapy-wise, I think if you are looking only for giving a medicine, a pill, and making him all right, is no longer true. I think in our center also we are using the deep RTMS with the newer protocols. We are finding interesting benefits with the negative symptoms, especially the hybrid TDS using for negative symptoms. One study which we are working right now, I'm sure within the next one and a half year, we are going to give the data to you all. So we might have a much better, but world is working for a betterment of our schizophrenia patients, and I'm happy with about that.
Thank you, sir.
Can I, sir?
Yeah, carry on.
Indira,
Please.
So it's a nice topic. You have nicely elucidated the whole thing. My query is 2 things. This cannabis as such is a schizophrenic drug. Like it induces kinds of, the delusions or hallucinations over a period of time. And again, cannabinoids are now a fashion to use. So what is your take on this? Is it really useful?
Not cannabis, it is cannabidiol, and cannabidiol is a synthetic molecule developed uh, with a structure which is slightly different. Right now, my first paper is published in Asian Journal of Psychiatry only this week on the anxiety disorder. It's a DCGI study. But we are now doing another study for the negative symptoms. Somehow we expect cannabidiol might have a benefit, but it's anybody's guess. There are a few reports of open label case reports which are published on cannabidiol in both negative symptoms and depression. So having said that, I will also might share with the larger audience who are participating here that I am part of the World Federation of Biological Psychiatry Schizophrenia group. Dr. Keshwan is the chair. We are now presenting actually on the 5th and 6th of World Congress of Biological Psychiatry. We are presenting the report of the role of cannabis. I thought the second part I'm covering, cannabidiol, you asked me. The cannabis seems to have a significant role across the world in both disease modifying and disease causing effect. And at least in those, not everybody, but in those vulnerable patients.
So about
There is one question in the chat box.
just one. Just one.
It is by Dr. Pavan Kulkarni. In the light of your presentation, is it correct to say that each subtype may evolve into different entity?
Very beautifully said. I think that's a very simple kind of a thing, but there are multiple subtypes that is now well recognized. And why does, and what are the factors which would go on to develop these subtypes? We are in the process of understanding. Pawan, I think your question is well. We today, for example, we talk about a positive subtype, but I think we should take a mixture of positive, negative, and cognitive together. And each subtypes are different. As you can see in our day-to-day clinical practice, also some of the patients recover very beautifully with olanzapine. They remain. Those are the so-called what Kreplin also said as a good prognosis. But I think your question is valid. We today we might say we might go towards that direction, but we are not sure fully because something more in the puzzles we need to fill in.
Thank you, sir.
Thank you, Pawan.
Thank you, sir.
Prasad Rao garu, just one more query. In treatment resistant schizophrenics, that's a significant number of people who are suffering. What do you usually prescribe? Because despite the typical, atypical, and other drugs that are used, still, there are quite a number of people who are resistant to such drugs. So, what is your take on it? The second one is like, some people respond to olanzapine, some to risperidone, though the mechanism of action is the same. What's your take on it?
I will answer your first question first. Clozapine is beneficial in another 30% of patients. Normally, about 45% only respond to the first. The CATI study also showed the same, more or less same figures. And clozapine, if you add, another 25 to 30% respond. So we are left with about 30 to 35% of true resistant. On clozapine, if they don't respond, we call them ultra resistant, where augmenting with a specific second generation molecule seems to have a very clear evidence. Right now, US FDA has approved brexpiprazole also for treatment resistant as one of the indication. That's the only molecule in the second generation which has an approval by the US FDA. But as you correctly said, risperidone, olanzapine, amisulpride, modafinil, and there are some odd researchers, and one of the thing is minoxidil responsive case. Remember the anti-inflammatory theory of psychosis. So I think what we are now looking for is, especially in this last 30-40% of patients, we need to look for a better answers. But what is now emerging in this last 5 years is neurostimulation by one deep TDS, and one of the earliest paper came from Ganesh Venkat Subramaniam's table from NIMANS. But deep RTMS, again, focused protocol for 14 sessions to 20 sessions is one more. So these are the options we have at this point of time. Now, answering your question, for me, each atypical is not same at all. If you go back and look, I didn't present because it's a very larger schizophrenia data. I thought I would only talk about broader picture than the narrower picture. But each, for example, the amount of D2 blockade, the amount of H2EA blockade, and the differential D3, for example, amisulpride is different because D2, D3, they have a different ratio. And wherever D3 is there, cognitive improvement will occur. And the newer molecule, as told by G.V. Raman Rao in his initial things, the one I'm doing these trials in my center right now, is a D3, D2, and 5H27 molecule.
Prasad sir, unmute. Tech support.
Sir,
So Prasad sir, unmute చేయండి. Prasad sir, unmute.
చేశారండి మళ్ళీ ఐ థింక్ అగైన్ మ్యూటెడ్.
I don't know why is he muted. Prasad sir, we are not. Sir, you are not audible.
Hello, Mr. Arvind.
Yes, sir. Yes, sir.
Is sir?
Prasad sir is not audible.
Sir. Can you unmute?
That's going to be that kind of a search. So all atypicals are different. For example, brexpiprazole and brexpiprazole and aripiprazole or hello. Low network bandwidth and Ramani. Hello.
Yes, sir. You're
You're audible, sir.
So what I was saying is that all atypicals are different in terms of their own acceptability for the each receptor site, and we are looking for the D3 and H27, and there is one molecule which I'm right now working. That's my first submission. Second submission is aripiprazole and brexpiprazole are slightly different for negative symptoms, but you have to use judiciously. And hello? Yeah.
yes.
Molecules are not same. They are different. In between, I'm getting muted by somebody.
Okay. So they want to close the session.
Maybe they want to close it.
No, it is an excellent presentation, Prasad Rao. Wonderful, wonderful presentation. Thank you very much. Okay, Nagaraj garu.
Thank you, Andy. Thanks. So it is, I mean, an enjoyable evening, and thank you, Dr. IVL and Dr. Sharath, Dr. GVS, and all rest.
Thank you, G.V. Ramana Rao garu, for the
Thank you,
opening
sir.
remarks.
Thank you very much.
Sir,
Thank you.
I request Kishore to present vote of thanks.
Sir, okay. So, good evening, everyone. It's my pleasure to present vote of thanks on behalf of IPS AP chapter. First of all, our heartfelt thanks to Prasad Rao garu. Sir, it's really wonderful, sir. We got new insights about schizophrenia. Hope that this session will be very useful in practice. So, and special thanks to NN Raju sir for chairing this session, and also a special thanks to G. Ramarao garu for introducing the topic, and who is the chairman of the CME committee of IPS AP chapter. And I thank all the office bearers of IPS AP State Bank chapter for supporting this academic sessions and being part of this. And I thank all the participants who have joined this session and made it successful. Not but not the least, our thanks to Sun Pharma people for supporting this program. Thank you, everyone.
Thank you.